Kia ora, everyone. It's 7 o'clock, so I propose that we get started. Apologies for anybody who was waiting in the waiting room and wanted to join a little bit early. We had a few technical difficulties, which is always a lovely way to start. Certainly put my blood pressure through the roof. So just before we kind of get into it, could I ask, I know there are lots of people joining as I'm talking. Could I ask, firstly, can people hear me? Can somebody
Yes.
nod? Oh, yeah, okay. I'm just going to ask Manita, who is the Vice President for Te Māramatanga, to open us with karakia if possible. And can I just also ask, can people make sure that their microphones are muted, just so for the background noise? Thank you.
Good evening, everyone. I'll start off with our karakia. Whakataka te hau ki te uru, whakataka te hau ki te tonga, kia mā kina uta, kia mā taratara e tai, e hia ki ana e atakura, e tio, he hoka, he hauhu, he hei, mauri ora. Kia ora.
Thank you, Manita. Sorry, I'm a bit distracted here trying to admit people. So welcome everybody, and thank you so much for joining us for our webinar tonight. I'm just going to do some housekeeping before we let, is it Mandy or Amanda? Mandy, do you prefer?
Mandy.
Mandy, before we let Mandy get on with her presentation. And also just to introduce myself. So I'm Sarah Jane Rewati, kia ora. I'm one of the board members for Te Māramatanga, and I also work for Te Whatu Ora Waitemata as a clinical nurse director. And just to acknowledge some other members of our board who are present on the screen tonight, and hopefully I don't miss anybody, but I can see Suzette Poole and I can see Manita, and I think I saw Inido, our president, joining. I'm just going to see if I can see anybody else. If I've missed anybody else, either sing out or accept my apologies for not seeing you on the screen. So just with regards to some housekeeping, we didn't seek questions prior to this webinar. So if you do have any questions, I'll try, if you pop them into the chat, I'll try and keep an eye on them as Mandy's doing her presentation. But we'll probably address that at the very end, if that's okay, Mandy? Yeah, okay. I think that's probably better because we don't want to interrupt the flow of thought. I know what that's like. And also just to, again, reiterate, if we can mute our microphones, sometimes the background noise can be quite distracting. Perfect. Okay, so if I may just introduce Mandy. So Mandy, I'll just give a very brief overview, and I'm sure that as part of your introduction, you will say where you're from. But Mandy is a nurse practitioner, within the eating disorder service in the Waikato, and she is going to be presenting tonight for us on the topic of differential diagnosis. So thank you very much for that, Mandy. Would you like me to share your presentation for you?
That would be awesome.
Okay.
I'm one of my fears is the technical side, and I'm on my iPad and it is on there, but I'm not quite sure where to find it, but I did send it to you. So
not a problem. Just let me know when you need me to change, what's the word I'm looking for, to move it forward for you. Yeah. Give me a second. I've got a couple of tabs open. Yeah. Okay, am I sharing screen?
Yes.
I am. Okay, I'll put it in presentation mode. There we go. And so is it the first page for you?
Yeah, I can still see all of it though. That's it.
Yeah. Okay, perfect. Thank you very much. Okay, over to you then, Mandy.
Oh, thank you very much, Sarah Jane, and thank you to everyone for attending. I know for me, this is usually I'm thinking about going to bed, so I'm really impressed with the turnout here. And I was one of those people that was having high blood pressure in the waiting room. I've been there since 2007 with the nerves going.
This isn't my usual style of presentation, so please bear with me. I shall try and navigate. So kia ora, everyone. My name is, well, it's Amanda Shanley, and everyone predominantly knows me as Mandy. I am a nurse practitioner working for the Specialist Eating Disorder Service in the Waikato. Just a little bit of background about me. So I trained many years ago as an enrolled nurse general in the northeast of England, a job that I absolutely loved. It has changed so much. I was sat here reflecting on how different it is nursing to how much it was different then. So I was a general nurse and wore a uniform and wore a hat, and got told off for not wearing my hat once. I was cleaning a trolley and I'd taken it off, and how the times changed. Like now we know that evidence-based practice, that the hats were just clinger of infection, but how times change. After qualifying as an enrolled nurse general, I went into the Royal Air Force for a few years. I came out and retrained as a mental health nurse. I've worked in the care of the older adult services and rehabilitation, community services, crisis team, home treatment and consult liaison. I started working with people that experience eating disorders approximately 20 years ago, and that's where my passion is. It's what I absolutely love doing. In between, though, I did have a little break as a CNS working for the community mental health teams here in New Zealand. I moved over about 13 years ago. And I have been back in the eating disorder service probably about the last 6 years as a role as a CNS, then a clinical lead, and eventually doing another 3 years training. It did seem a good idea at the time to become a nurse practitioner, a role which is absolutely amazing, and I'm still finding my way alongside. So I've been invited to discuss and present on differential diagnosis. It was something that we covered a lot in my nurse practitioner training. And I think Tony's request was to demystify what differential diagnosis is. So hopefully we'll be able to do that. And if I can have the next slide, please, Sarah Jane.
You may. Sorry, I don't know why it's not. I don't know why it's not moving to the next one. Sorry. What? Oh, there we go. It was just a bit slow.
So that's fine. So the objectives, I've got cultural safety, which runs is embedded through any training that I do, and then I've got what is differential diagnosis, why it matters so much now in nursing, frameworks for differential diagnosis, how it affects in mental health, some clinical reasoning, how to rule in and how to rule out with diagnosis, some practical application for nurses, and there's a couple of case studies, and then we'll hopefully finish with discussion and any questions. Thank you. We'll go on to the next.
You just have to bear with me. It seems to be just deciding it wants to be a little bit slow. It doesn't want to listen to the...
That's okay.
Oh, there we go.
Sometimes.
Yeah, you can take a breath.
So as I said, any training, any work I do, embedded is that, and is the working with the treaty, which is so important, and using those principles for autonomy and self-determination with the clients that we work with, making sure there is equity, making sure that it's genuine options from a Maori perspective, and that we have authentic partnerships. Yeah, we'll go to the next one. So why this training? So this year in February, the Nursing Council dropped from 40 competencies. I remember how difficult it was starting to look at those, to actually 6 standards for registered nurses or 5 standards for enrolled nurses. One of the ones that has changed, though, and part of what we need to be aware of as nurses, is that we're able to develop a differential diagnosis within our comprehensive assessment, using our clinical expertise, using current evidence to inform a plan of care. And I took this quote from the Council of Nursing. So we use substantial nursing knowledge to inform comprehensive assessments to determine health needs, and we're going to develop differential diagnosis, plan care, and determine appropriate interventions. Thank you. We'll go next one. So this is a differential diagnosis. It's a systematic process. It distinguishes from any illnesses, diseases, or conditions from others that present with similar signs or symptoms. And as we go along, you'll see often, and probably in your thoughts now, that often things that we see, we think it's something, but there's a similarity. So by using a differential diagnosis, hopefully we're going to be able to sort of rule out the ones that we don't want, or they're not correct, and get the ones we want. And we're going to use history taking, physical examination, investigations, and clinical reasoning to identify what the most likely diagnosis is. And I do understand, and being a nurse, and still a nurse, however, as a nurse practitioner, I do diagnose. And when I wasn't officially, I couldn't diagnose. However, I could do a nursing diagnosis, and I was also aware of what symptoms and presentations were suggestive of. Just because we can't, as nurses, can't officially diagnose, that doesn't mean that we can't actually have an idea of what may be going on. Okay, we'll go to the next one. So this is Sir William Osler, and this is one of the slides we had when I trained as a nurse practitioner, and it's I guess it resonated with me, and it's from a long time ago, but he said to his students to listen to the patient. He's giving you the diagnosis. So when we sit with the patients, when we assess them, and we really listen and we really observe, instead of going in with our script and of what we want to know, but we actually listen to what they're telling us. He was, it was quite groundbreaking, and he sort of suggested that the art of medicine, it wasn't lying just in technology or in tests, but in that human connection between the doctor or the clinician and the patient. And yeah, I hope we can still do that. So even that we're doing this and we're looking at all these different ways, but just always really listen and observe. Thank you. So this one's a bit wordy. Differential diagnosis, they are a key element of nursing practice that's going to incorporate the history. Just going to get rid of that. And physical assessment, and using our clinical and critical reasoning skills. So as a nurse, we're working as a part of an interprofessional healthcare team. We contribute to expertise to evaluate symptoms, we interpret findings, and we consider various conditions. So differential diagnosis, they're not the official diagnosis. We're just saying that these are things that it might be, and it is a step before determining what condition could be causing the person's presenting symptoms. As like I've said, there are similar presentations where there's quite different diagnosis and quite different treatments. When registered nurses use critical thinking and decision making to assess a patient, we make a clinical judgment on what the health issue might be. Is anyone else's phone giving an emergency alert? Mine's just going off. I do apologise. I'm just going to switch off. Just bear with me. I'm really sorry. I don't know why it was doing that. I thought it was another lockdown or something. It's going mad. I think it's just trying to connect to my watch. So apologies about that. So we're doing the assessment on in order to develop a plan of care. So it's not a definite diagnosis, but it's the step before. So we're looking at the likely cause of symptoms. Then the nurse will report the observed symptoms, what action's been taken, and it's usually as part of that MDT, that part of that teamwork, but predominantly it will be the primary clinician, whether that's a doctor or a nurse practitioner, before a definite diagnosis is made. Thank you. Next one. What the purpose is to accurately distinguish between conditions that have similar symptoms, and you're going to look at creating a possible list of causes, and then you systematically eliminate or you confirm them, leading to a correct diagnosis and appropriate treatment. And I love all the physical side of things, so I put 3 things that were quite similar on there. So we have the first one is the psoriasis of the skin, and the second one is ringworm, and the third one is hives. So they all look sort of fairly similar, but when you're actually looking at differential diagnosis, you'd be looking, you know, to get the right diagnosis, because they're all different tests that you need to do. And they're all different treatments. So for psoriasis, you would be using the steroid creams and light therapy and different creams. And to find out, you'd have to do a skin biopsy. For the ringworm, would be antifungal medications, and you would do a skin scraping test and send off for culture. And for the hives, the treatment would be antihistamines. But again, part of that is looking at the allergy, the skin test and blood test. So as you can see, so 3 things can look quite similar, but can all be very different. Next slide, please. So for frameworks, so using frameworks, and I've picked a few, and these are things that I use because I don't just use one framework. And what I find, a framework actually is going to help us provide a structure. It's a comprehensive understanding of a person's needs. It also helps us consider Māori perspectives and the interconnectedness of factors, rather than just looking at the immediate symptoms. Thank you. The next one. So most of you, if you've done study, will probably be familiar with the Bloom's taxonomy. And again, I was sort of going through my study and things that I use, and I still use this. And I think, thinking back to when we're student nurses or pupil nurses, and when we're learning, and the first thing we see, and then we remember them, and then we start to understand, and then we start to apply what we've learned. And then analysing, we'll use case studies. We can differentiate them between symptoms of various psychiatric and particular mental health nursing, any psychiatric disorders, and we're starting to perhaps even then look at, you know, without realising we're differentiating. So we are looking at maybe some differential diagnosis in there. And then we're evaluating. We look at what we're doing as well, and if we've got an idea. So we did, you know, we've done some treatment that's worked, or some treatment that hasn't worked. Again, I think you can link that into your differential diagnosis. And then finally, as the creating, you're going to create that individual, and something that we do so well as nurses is that individualized holistic care plan to meet the unique needs of the person. That was my first framework. Thank you. On to the second one. And we've got the Tawhara Tapawhā model. So most of you, hopefully, or all of you will be familiar that we're looking at the 4 walls. So we're looking at hopefully none of those walls are weakened or broken. And the walls represent the physical, the mental and emotional well-being, family and social health, and the spiritual health. And the land is then the foundation of the model. But again, that's sitting alongside when you're assessing, we're looking at things for that. And this all comes into play and when we're looking at differential diagnosis. Thank you. The next one. This is one that most of us are, I guess, as well familiar with. We're looking at biopsychosocial, cultural and spiritual model. So we're looking at all those different factors, and it's amazing really what our brains are doing as we do go along, and how we're processing and what we're looking for. So a nursing role in this is to gather and present the observations objectively. Again, we're ensuring cultural perspectives are representative, and we're working in partnership with the patient and the client and the whānau. And we also hopefully advocate for holistic models, so which alongside that is the Te Wharatapawha. And we're ensuring again that cultural safety is alongside of that. So this is us gathering all this information, the comprehensive assessment, the critical thinking to get to our differential diagnosis. Thank you. Next slide. Again, the nursing process, an oldie but a goldie. So as an 18-year-old, this was what was almost like tattooed for us. Slightly different because we didn't have diagnosis, and this one we do have a diagnosis, and that would be a nursing diagnosis. I would suggest as we're assessing, we actually start to look at differential diagnosis, and then the planning, and then our implementation, evaluation. And I still think this is so valid in what we do, and I like it. It's simple, it makes sense, and it still stands the test of time. Thank you. Next one. Particularly coming from my training as a nurse practitioner. So we're mental health nurses. However, we are holistic. We will look at everything that's going on, and we look at systems. When you meet with your patients or your clients, they're not just going to present with depressed or anxious or psychosis or an eating disorder. They're a human being, and there are lots of organ systems going on. In fact, there's between 11 and 12 organ systems. There is officially the immune system doesn't really fit in that, but I've put it in that. But you can see how many things to sort of consider. And again, we go back to the sitting, the talking, the investigations to get that real overall picture. Thank you. Next one. So part of the process again, and I'm sorry, it's quite repetitive, some of this, but it is quite straightforward, and hopefully I am demystifying. So we're gathering information. We're going to list possible causes, looking from common causes to possibly rare causes, from benign to serious. And then we're going to rule in and rule out conditions which are based on the evidence that we find, and hopefully then we'll arrive at the most probable working diagnosis. We'll go to the next slide, please. So a favourite of mine, Shrek. So what do onions and ogres have in common? So ogres and onions both have layers, and this was a comparison famously made by the character Shrek. He explained that ogres, like onions, have complexities and depth that aren't immediately apparent on the surface. This means there's more to them than just the initial appearance, suggesting a deeper character, emotions, or other hidden qualities beyond the outer form. So one of my sort of hopefully take-home things is keep peeling and think of Shrek. Thank you. Next. Dr. Theodore Woodward was a doctor in 1950, and when he trained his medical students, he trained them to formulate different diagnoses, looking at possible causative factors, but he always wanted them to prioritise from the most likely to the least likely. So his famous saying was, when you think of hoofbeats, you think, and if you hear hoofbeats, you think of a herd of horses, you don't think of zebras. However, my experience, there are always zebras. So it's something to consider, especially in differential diagnosis. Thank you. Next one. So we talk about ruling in and ruling out. So like being a detective, this is what I find really interesting. It's just, again, it's like that unpeeling, it's being a detective, it's looking for clues. So in ruling in, we're going to look at diagnosis, we're going to perform tests and look at things that make it highly likely that a specific condition is present. And while we're looking at ruling out, the diagnosis means to look at tests that definitely exclude conditions from the list of possibilities. So the next slide, please. And this one's very similar to what I've just said, but in mental health, so again, we're going to rule in finding evidence that confirms a specific diagnosis. So if you're looking at depression, you're looking in the DSM. Does it meet that? And ruling out eliminating conditions but could be causing the symptoms but are unlikely. So you might be looking at blood tests, looking at thyroid, might be looking at vitamin B12, things that may cause depression. So it's just that sort of that balancing. We'll go to the next slide, please. And again, about being the detective, when you have, and this is from Sherlock Holmes by the author Arthur Conan Doyle, when you've eliminated all which is impossible, and then whatever remains, however improbable, must be the truth. So it is really like being that detective with differential diagnosis. So the practical applications, so as part of when you're doing your PDRs or APRs or going for your nurse portfolios to evidence your differential diagnosis, which is in 4.2, what they want you to provide is a specific recent practice example from your work of how you used your knowledge, critical thinking, comprehensive assessment, how you gathered your assessment data, and how you considered multiple conditions with similar symptoms, how you communicated with a healthcare team, and how you reported your findings to the primary clinician, leading to a definite diagnosis. So I guess it's sort of something as you go along, and we're always told to sort of keep notes and be reflective. And if you come across cases and in your assessments, start to think of what else it might be. You know, it might not be straightforward, you know, and I'm assuming you all work in different fields within the mental health field. Start keeping some notes, and then if you do need to, when you do need to put it into your portfolios or into your for your competencies, you've got those examples. And it does take some getting used to. I think when we start looking at differentials as nurses, because we've always used the nursing diagnosis, we would use the evidence-based or informed evidence-based care as well, and we document clearly, which is something that I think as nurses we do really well. We'll go on to the next one. So I wanted to talk, there's a couple of case studies. This is a 22, and just to show you, so sometimes cases aren't as straightforward as you think. This was a 22-year-old European female. She was from New Zealand. She was referred to our service with suspected anorexia nervosa. So she had significant weight loss. She got low mood. There was a marked restriction of oral intake. She was only eating small amounts. She had an assessment, but at the time, due to concerns about her medical compromise, this had been going on a while, she was admitted to the medical ward for physical stabilisation and refeeding. The mood continued quite low, and a physical deterioration continued, and it raised concerns for a possible underlying organic pathology. Then blood investigations revealed a serum cortisol, which was really low, of 43, which prompted a referral to endocrinology. And following this assessment, she was actually diagnosed with Addison's disease. So it actually had happened slowly over months. Nobody knew what was happening. She was assumed to have an eating disorder. And Addison's affects in different ways. She had loss of energy, extreme tiredness, fatigue. She felt dizzy and fainting when standing up. And again, when we checked her OBS, often from starvation and malnutrition, this can affect the observations. So it was quite a hard case to give a different diagnosis. At the time, our differentials were probably anorexia nervosa or ARFID, which is avoidant and restrictive food intake disorder, and we were ruling in, ruling out. So for anorexia nervosa, she met the criteria with the low intake. She couldn't gain weight. She wasn't eating much. However, she wanted to gain weight. She didn't have the eating disorder cognition, so we put this was potentially like an ARFID presentation. However, luckily the follow-up in hospital was able to find that she did have significant low cortisol level. This can be life-threatening if not treated. Since then, the client and her mum, she's got a lot better. She is on lifetime treatment. She's managed to gain weight and eat. There is no evidence of an eating disorder. She requested to be discharged from the service and didn't require any further follow-up. So it was a big learning curve, and I thought it was a really useful example of, and like, sometimes you think you see a client and yeah, I've got that, and we go through the DSM and you're matching it, but sometimes underlying conditions, it's not always so straightforward. Thank you. Go on to the next one. So case study 2. This is a bit of I have based it on a couple of different cases, but we do see this quite frequently. So this is a 19-year-old Maori woman. She presented with her mother to our service. So over the last 6 months, she's lost 12 kilograms, so restricting her food. However, her BMI is within a normal range. She did describe intense fear of weight gain. She was weighing herself daily. She was avoiding eating with her whānau. Her periods had stopped, concerningly. Her whānau say she'd become withdrawn, quiet, and was getting upset very quickly. She reported hearing that her ancestors in her dreams telling her that she must stay pure by eating less. She was quite driven by this, and she also reported some trauma about bullying in her body at school. So if we were to look, and I say this happens quite frequently, and one of the things we realise is when Maori present to our service, often they're not presenting in the same way. This is often quite a typical presentation. We were told when I first started work for the eating disorder that Maori don't get as many eating disorders as Pakeha. Actually, they do. They actually get more. It's just that they weren't being diagnosed in the same way. Now things are starting to change, and I think part of this is being able to use some differential diagnosis when people are seen or patients are seen. So for this young lady, occasionally, if they're seen first in primary care, they may be declined a service because their BMI is in normal range. However, looking at the whole picture, the weight loss, the restriction, the eating disorder cognitions, the history of trauma, and also looking through that cultural lens with the shame and how food from a cultural side of things, it's so difficult. We were able to look, I guess, rule in, rule out. So for this young lady, she didn't meet criteria for anorexia nervosa. However, she did meet, and she didn't meet criteria for bulimia nervosa. And we were ruling in, ruling out. We checked all the bloods. We weren't concerned about the bloods. But what we did manage, that we ruled in, was that this lady, this Wahine, had a presentation of what we call atypical anorexia nervosa, which is in the DSM-5 over under OSFED, so other specified feeding and eating disorders. So it can be just as dangerous, and the person can just be as unwell. So using differential diagnosis, we came to that conclusion. So that was my second example of case study. And I'll go on to the next slide, please. So I guess one of the takeaway, because I'm coming to an end now, and hopefully we'll be able to have lots of some questions and some discussion. But one of the things is when you're working with any of your clients, and whether you are looking at your differential diagnosis, is please do remember to check for those zebras. Next slide. And then a discussion. Thank you.
Perfect. Just give me 1 second so I can stop sharing. Fantastic. Thank you so much for that, Mandy. I'm just going to quickly check and see if anybody's put any questions in the chat. Otherwise, I will then open the floor. Somebody answered your question about Shrek and said layers.
Yes.
Sorry, I see people have asked questions about cameras on and off during the presentation. When I was sharing my screen, I couldn't see the question, so apologies. Okay, would anybody like to ask Mandy any questions about that very interesting presentation? Hiniroa, you've got your hand up. Kia ora.
Ngā mihi, Sarah Jane. Ngā mihi, Mandy. Thank you for bringing a kōrero that and probably demystifying some of the things that I thought about eating disorders for Māori. But I'm just intrigued by the knowledge base around the language that you use, the models that you use. Just very exciting as well. So just thank you so much for sharing. I think I learned a lot about how you use the model plus the diagnosis to work and build the frame of getting the conceptuals or the concepts of what it looks like in a Māori wahine or a Māori kōtiro. So that was really helpful. I think the other part is, do the parents go with the rangatahi or with these young women when they,
Yeah, we invite. So, kia ora, thank you so much. That's just beautiful feedback. I've been so nervous about doing this, so that's just so lovely to hear. Whenever we offer an assessment, we try and contact the client, whoever's coming into assessment. We always offer for them to bring their whānau or support people. I think I had 3 whānau in with a young wahine I was assessing the other day, and it does make a difference. And part of the therapies we try and include, even for the adult therapies where it is individual therapy, we always ask for permission if we can to speak to the whānau, because it's such an important journey of recovery from eating disorders. I think any mental illness, but in particular for us working with eating disorders, and having that whānau support is vital.
Thank you very much, Hiniroa. Kim, you've got your hand.
Thank you.
Kim, you've got your hand up.
Kia ora. Thanks, Mandy. It's been really interesting. It feels like permission to do detective work. Hey, I guess, there's that kind of knowledge that as nurses we've always done nursing diagnosis. With this kind of differential diagnosis, are we looking at using DSM, ICD? What kind of, how do nurses know what diagnostic framework?
It's a good question, absolutely. So when I trained, it was like this, almost like this elusive DSM. We weren't encouraged to use it. Anyone can look in the DSM, anyone. And even before I qualified as a nurse practitioner, and I remember, and I think Tracy's here, Tracy Forward, was my tutor, and I think she also, she talked about the DSM and looking at it. And my other tutors, even before I qualified, there was nothing to stop any of us as nurses of looking in the DSM and talking to the clients. I'm not officially able to diagnose, but this is suggestive of major depressive disorder, or anxiety, or post-traumatic stress disorder. Yes, officially we can't, but we can have a nursing diagnosis, and we're certainly, we're skilled enough with our critical thinking and comprehensive assessment to come to that decision. That's my opinion. It might be different for other people, but that's my opinion.
Thanks. Yeah. So we use DSM in mental health. What do they use in the general space? That's just a curiosity question.
Yes. There is a certain thing. So.
Can I answer that? Can I help?
Yes, please.
It's Amelia here. I work with Mandy. On the general side, they use the ICD-10. If you've heard of it, it's a classification for medical diagnosis as well. But previously, mental health diagnoses were classified with that too. But due to some confusion, we've now resorted to using and getting the help from the DSM. And you may be aware that they have kind of evolved from DSM 1, 2, 3, 4, and now we are on DSM 5. But yes, to answer your question, general side, they use ICD-10.
Thanks, Amelia.
That was a great question, Kim. Can I just ask, on just adding on to Kim's question, how have you found, or have you found that our medical colleagues have responded? Have our medical colleagues responded positively to, I suppose, you providing a differential diagnosis, or even a diagnosis at all? Has that been received well?
So my experience, and again, I'm speaking from my experience, I've had a really positive journey. I had a really positive journey as my nurse practitioner training. So I worked with a lovely consultant as part of a medical team on an inpatient for the older adult and mental health. And I was encouraged to doctor speak as well, which is a different language. And to be a lot more succinct than I know I do tend to go off on a tangent. So they sort of rein me in. Yeah, they were very appreciative of it. And I find even in my role now, we get the regs coming through who've got a lot of medical experience. Very open. I go up to the wards sometimes and do talk to some of the regs up on the medical wards. And majority, I'm not saying 100%, but majority so far, I've had a really positive experience. I am aware that not everyone has, though, so I can only speak to my role, and maybe it is the role in the eating disorder, because it does baffle quite a lot of people, and it causes lots of anxiety often with sometimes our medical colleagues. So often they're always so pleased to see me, which is great.
Fantastic, thank you. Manita, I'll answer your question, and I can see, Rose, you've got your hand up too. There's also a question in the chat.
Okay, so Mandy, this is about your case study number 2 about the Māori Wahine. So you talked about she was hearing her was it her koro or somebody telling her something? So
Yeah.
did you rule out psychosis?
So that would have been something, yeah, that we would have looked at and ruled in and ruled out. From a cultural perspective, and with her mum being there, and also we can ask for some cultural advice, but it was certainly a consideration. One thing we are aware of as well, that severe starvation can sometimes cause a psychosis as well. So it's something to be aware of, and when the brain is adequately fed, that will revert, and that's only in extreme conditions. But it's certainly something we've heard of. And also a lot of the clients we work with, that is the eating disorder voice. It's not the same as hearing voices, but they describe it as this voice that's part of them, that they hear, that tells them not to eat. And that's for majority of clients. The voice will tell them that often that as a staff are just going to make them fat. Don't listen to us, don't believe it, they need to exercise more. It's such a punishing voice, but it's not in the true sense of a psychosis. It's a eating disorder voice that starvation often triggers.
Okay, because I have this thought, and I know other Māori, we have the same thought as well, is that our belief is that an eating disorder doesn't really fit the brief of a Māori, because we believe that it comes from a privileged kind of a stance, whereas white people, they can give up the food because they've got heaps, but Māori don't. So that's why we don't tend to, the saying momo, we don't waste food. So that's where I'm kind of struggling with listening to the story about the second case study that you did, because it seems quite interesting. But I'll still think about it in my head and decide. But that's the stance that I have always taken, that I believe.
No, thank you for your comment, and for the feedback. We get a very, I'd say, large referral of Maoris with anorexia or atypical anorexia, and you point about the food, and there's just all that shame that goes with it, because like you say, from a cultural thing, you don't waste food, so it's even more difficult, the shame and the guilt often that the clients that I assess. But if we look at our numbers, we do have a large amount of Maori and Pacifica clients referred with eating disorders, and not just with bulimia or binge eating, but anorexia nervosa or atypical anorexia, and those numbers are increasing, and we do keep the data.
Okay, it's quite interesting. Thank you.
You're welcome. And that's one of the things we're doing to educate in primary care, in GP practices, because they often weren't getting picked up. They were going round and round in circles, because again, they don't get eating disorders, or the BMI's within normal, but actually they weren't very well at all. So it is about just increasing the knowledge, and I guess just that understanding from all aspects. And I really take on board what you said, and I have heard Maori clients that have said, saying that the shame and the guilt, and how can I be like this? I can't waste food, and especially for someone that has bulimia as well, that eats and then goes and vomits. So
Thank you.
Thank you.
Rose, I'm aware that you're next up, but I wonder if Hiniroa and Kelly had questions related to Manita's initial question, or whether they're new questions. If they're related to Manita's, do you want to go ahead and ask the question?
Sure. Sorry, Rose, it won't take a minute. Thank you. I kind of thought about what Manita's saying, but I also think about what the changing world is like And also, given that we've moved off the Papakainga into city and Taonenui, or the larger townships like Kirikiri or Hamilton. And I'm mindful that the bullying at schools, in particular all girls schools, and how ugly those scenes can be. And I'm talking about my own moko, who was at an all girls school, and the abuse of just slightly overweight, and the kōrero that comes out of their mouths is quite a horrific. And when you're not used to being called names or not being told that you're fat and you're ugly and you got nothing, that hurts, eh? And so you patu their wairua. So I kind of hear what Meneta's saying, and I know that kōrero of old, mau kai. Tūhoe's got a whakatauki, mau kai, mau taonga, mau tangata ki te pō. And it's very much about that concept. Don't waste anything, including man. And so they were forever battling because of the loss of our males in our hapu and iwi. So just come back to your kōrero, but I think this is about learning for me and understanding, that there are tools that we've got as nurses, how we can diagnose our rangatahi, but it's also good, I'm just expressing, it's also good to have a cultural person in that space that may not understand what eating disorders are, but may be able to help in a mental health perspective. And that might be a better support for you should you decide to take that route to get a better understanding of Māori and Pacific rangatahi that use the service. Yeah, thank you. Thanks, Manita.
Thank you, Kia. We've actually just we've expanded our team, and we've just we're so grateful. We've just employed our first Māori clinician. She's an occupational therapist, and she's been here a week, and we're already learning so much from her. She brings so much with her. So watch this space. Hopefully we'll have more and develop more.
Fantastic, thank you. Kelly, was your question related to the original question by Manita, or was it a new question?
It was a little bit of everything. Kia ora, Mandy. Thank you for your kōrero. It's been enlightening. I just wanted to say I was a nurse at the rangatahi unit for 13 years, and I don't believe we ever had a Māori rangatahi with an eating disorder. We had a couple of boys, but no Māori. So it's interesting to see the level of, or the amount of Māori coming into your service. And taken into account what Manita said and Hiniroa about the particularly with Manita around kai, and also about kai being quite a big part of our cultural engagement as well. Second point I wanted to also make was having whānau around is super invaluable. It's an opportunity to get whānau view, educate and support as they travel the journey with their rangatahi. And second of all, the other thing I was going to say was this is an example from that occurred maybe about a month ago in our service, where a wahine, she's under our service. The prison called and said that this lady was, she was really fat, she was unconscious. Well, not unconscious, but she was very different from the day before. So their first protocol was to ring us, and we're like, well, you know, it doesn't sound psychiatric. You need to get her into hospital. She went into hospital. She had a whole pile of tests. She stayed overnight. She came back. She looked lively, and then again the same symptoms repeated, and she went back into hospital, and then she was retested and found out she had I don't want to say what it is, but it was a physical condition that she ended up with. So it was, you know, they needed to go back and do their tests as well, to look at that diagnosis and not particularly look at a psychiatric point of view. But thank you.
Thank you, Kia ora, and I totally agree. And it's really frustrating for any of our clients that go into hospital, and within mental health services, often if there's a mental health diagnosis, it's put down to mental health. I've had people go in with a chest pain and it's been put down to anxiety, and it's not. It's a cardiac arrhythmia. So again, a lot of the time we're advocating, it's about looking past that label. It's shocking, actually, but thank you for sharing that. It does happen quite a bit.
Thank you. Rose, you're up next. Thank you for waiting.
Kia ora, everyone. My name's Rose. I work in the Hamilton crisis team. Mandy, I kind of want to ask from your experience. I've got a sort of special interest in neurodiversity and how that, you know, with differential diagnosis, how that can present, particularly when people are in crisis. From a nursing perspective, if I've got somebody sat in front of me, and because I read lots about neurodiversity, particularly like PTSD and neurodiversity, and I'm thinking in my mind, oh my goodness, this person has undiagnosed autism or ADHD. I don't feel that in my role with my qualifications, I'm in a position to maybe say that, even though I really feel that sometimes that might be quite a relief for somebody to say, you know, you're a 52-year-old female. Has anybody ever spoken to you about maybe the concept of either ADHD or autism? And has that ever come up for you? But I'm not sure, I guess. I'm also new to New Zealand. I came here in December. And I'm not sure what the kind of rules are around that kind of conversation. If there's not a diagnosis there, it's not my role to diagnose autism, ADHD. But if I really feel that that distress is possibly the root of that is, you know, the distress of the world when you perhaps don't know. Do you understand what I mean? It's like it's something that I'm coming across a lot, and I'm not quite sure as a nurse what I'm allowed to say and what I'm not allowed to say.
I think, hi Rose.
Hi. Hello again.
Hello again. We met the other day.
Yeah.
I think, I mean, absolute excellent point. And I think, you know, you're experienced. It's using your experience. You're using the evidence. You're using critical thinking. You're using comprehensive thinking. And I think if it's done, to me, again, in my opinion and what I think, you can. And often we will in our assessments, and I did before I was a nurse practitioner, someone's presenting, well, you think they've got ADHD. So when you're seeing some behaviours, I think if you're being authentic and and it's done with kindness and compassion, just, you know, have you ever been tested for anything like ADHD, and the same for autism? And for some clients, I've noticed it's such a relief and validation. And that's the response I've always had, and I would always be quite clear, I can't diagnose. When I was in it, you know, I'm not, but some of the things I'm seeing and from what you've explained to me, what are your thoughts? What do you think? And again, like from that slide, client knows. They'll often say, I think I've got ADHD, or I think I've got autism. Because, so I think that's totally appropriate for you to have that conversation, even though you're not officially diagnosing. And then again, it's working as part of that team and asking, you know, would we be able to look at getting, you know, you can do screening tests. We do screening. You don't have to be a psychiatrist or nurse practitioner to do a screening test. say ADHD, you can do a screen, and then looking at, does the client want to be tested, and following what that looks like.
Thank you. Yeah, that's really helpful. Thank you so much.
That's what
I'm very sorry, Mandy. I'm very mindful of the time. We've Rumbidzai, you've got your hand up. Do you have a question that you want to ask? And then we will need to close off the questions. But I'm just thinking if people still have questions, because I actually wrote down about 6 that I wanted to ask. Perhaps we can come to you, Mandy. I've got your contact details.
Yeah.
If people have questions, would you be open to answering some of them? Okay, perfect.
I'll try my hardest, yes.
Thank you. I don't know whether Rumbidzai could hear me. Do you have a quick question that you want to ask, or do you want to save it? I saw something in the chat from you.
When Rose asked about, as a nurse, how I can help with the client on differential diagnosis, because aware that we cannot diagnose, but how you've said, I think you've answered that we can just pose it as a question and ask the client how they feel. And I found this very informative. Thank you very much.
Oh, Kiara, thank you.
Thank you. Okay, look, I just want to thank everybody for attending tonight, but also to thank you, Mandy, for a fabulous presentation. It certainly generated a lot of thoughts for myself, and I know as a mental health nurse, and working with other nurses, lots of people have been quite anxious about what it means in terms of providing a nursing diagnosis and what it means to provide a differential diagnosis, and kind of the ownership that you have to take with that. I mean, I imagine we probably could have spent another half an hour to an hour talking about it, but unfortunately we haven't got time. So I just wanted to say thank you very much. And before we close, just to say, and I'm going to do a very shameless plug, anybody who joined tonight who's not currently a member of the college and would like to join, and we would very much welcome you, please feel free to get in contact. If you're on the fence about it, you're not really sure what we can provide for you, what we offer, feel free to contact. I'm more than happy for you to contact me, and I'm happy to talk through that. We would definitely welcome you with open arms. So thank you very much for joining, and then I will hand over to yourself, Mineta, if you wouldn't mind closing for us.
I'm actually going to hand the rākau over to our president, Hiniro. Can you
Thank
close
you,
us
Mineta.
up,
Sorry,
please?
Hiniro.
Making myself very comfortable waiting for you to do our karakia, Mineta, but okay. All right, then, whānau, tēnei te mihi kia tātou. Tēnei te mihi kia koe, Mandy, mō tō kōrero, tō kauhau kia mātou o tēnei kaupapa i te pōnei. Nā mihi kia koe, Mandy. Kia ino e tātou. Mā te rā e kawea mai te ngoi iara. Mā te mārama e whakaora i a koe wainga pō. Mā te ua e horo e o mahara. Mā te hau e pupuhi te pā kahukahu ki roto i tō tinana, i roto i koetana i te ao. E whakaore i a koe te humāri a tāhua, taura, o ake tonu ati. Kia tau. Have a great evening, everyone.
Thank you very much. Ka kite.
Thank you. Bye-bye.